how are you?
Hi, good, Louise.
Back at the state chamber. Relations, Mr. Rival here?
Oh, you do? She's our new lobbyist. Even though Jeanette and I have worked together for years through the Home Health Services Association, which they represented, she and I have worked together.
If we
and
could have
decided to
any
add her.
panelists or out in the audience, if you could come up, we're going to get this thing moving on time and make sure that we move along the discussion as well. We have most of the panelists here. It's my privilege and honor first to introduce the president of Kane University. And let me just say this, that Dawood Farahi has been someone who has been incredibly supportive of discussions, panels that we've had in the past, and he's an incredible leader, not only for Kane University, but the state of New Jersey. If you've walked around Kane or drove through the campus, you can see the incredible progress that Kane's made under President Farahi's leadership. President Dawood Farahi.
Thank you. I have a great job to welcome you to Kane University, and if you haven't been here before, I hope you come again. The issues you're going to be talking about is not only important to New Jersey, but the entire nation. Healthcare now is similar to the legislation that occurred in the 1930s on Social Security. The financial impact is immense. So I'm glad you're here, and I'm glad you are participating in the conversation. We also have another conference on March 13 on global health, which is part of the Human Rights Institute here at Kane. And if you have an opportunity to come to that, I hope you do, because today something could happen in Liberia, and you can spend millions of dollars here to affect something that you cannot affect. So I hope that you understand that portion of the process too. This important issue is being moderated by a great friend and an amazing person, the Republican leader of the Assembly, John Bramnick. And I should tell you, he's also a grandfather, 2 months going. I went and visited the baby last week. She is amazingly cute. And so her health care is also at question here. So welcome to Kane, back to Assemblyman Bramnick. Thank you.
If I could briefly explain why I've done this panel and a prior panel. Constantly, people come to my office who represent special interests or their interests. And the discussion goes as follows. Why are you here? We're here to tell you our position on this issue. Well, tell me about the other side's position. They don't really have a position. This is the fundamental flaw in our society, that we don't hear each other, or we don't listen to each other, or we don't accept each other's opinions. We need to be open-minded, and we need to have direct and frank conversations about difficult issues in our society. Well, nothing can be more complicated than health care. So today we've put together a group of experts. The only person I'm actually going to introduce, because I'm going to have them introduce themselves once we start questioning the panel, is my running mate, Nancy Munoz, the Assemblywoman who sits on the Health Committee. Nancy, welcome, and if you have any opening remarks as a leader in the legislature, please do so.
Well, thank you very much. I was a participant in the healthcare delivery system this weekend. I fell on the ice, as many people did, and fractured my wrist. And I had excellent care, urgent care in Berkeley Heights. So I recommend it to anybody. Thank you for doing this, John. I am a member of the Health Committee and also a clinical nurse specialist who's worked as a professional nurse since 1976 in all kinds of settings. And I feel that I bring a perspective to the delivery of health care and to the legislature because I always make sure that it's patient-centered health care. that we look at it from a perspective of the patient is at the center, and everybody else is we're providing health care in a quality, cost-efficient, and accessible way. So I'm happy to be here. I'm happy to be a participant, and I'm especially proud to be the running mate of John Bramnick and be in District 21, which is here. We represent 10 towns in Union County. Thank you.
Thank you, Assemblyman. Here's how we're going to do this. So it's real simple and clear. I'm going to go around the table and I'm going to ask a question. And I would ask the panelists to simply say who you are, no introductory remarks, no introductions to your idea, just answer the question. If you can't answer the question, just like Jeopardy, you can pass. Or if you're very neutral on the issue, just say you're neutral, or say you don't have an opinion. But I've been to too many panels, I've been to too many hearings where we never got to the issue. So, the question, I'm going to start with Michelle, and then we'll go right around the table. And once again, tell us who you are. If you mention the name of your organization and the title of your organization doesn't mean anything, just tell you who you are. So, Michelle, what is the most serious problem with health care in New Jersey, if there is one? And tell us who you are, and then tell us what the problem is. Well, I assume you see some problems. If you don't see any problems, just pass to the right.
Good afternoon. Thank you very much. Michelle from the Medical Society.
See, this is scary. Let me tell you why it's scary.
No, it's because I'm sick.
Oh, you're sick from the Medical Society. You got 4 doctors on a
I
panel.
wasn't clearing my throat for a soliloquy, I swear.
Yeah, actually, it's really appropriate that you're sick. I think that works out well. Was you couldn't get an appointment? Sorry. Okay, go ahead.
Unfortunately, there are several problems with healthcare, but I think the most important one that New Jersey physicians are facing in trying to make sure that they adequately take care of their patients in a team-based, quality, cost-effective way, unfortunately, is all of the many interactions they have with insurance carriers today. So that includes difficulty with contracting, difficulty with payment, not reimbursement, but payment, difficulty with coverage of procedures.
So I'm clear. The problem, at least from the Medical Society's perspective, is that they have problems dealing with insurance companies.
Correct.
Good. Tell us who you are. We're going to continue around. And we'll get more into that detail because there'll be people here who represent insurance interests, and they're going to say why you're having problems.
Same question?
Same question, everyone.
Great.
We're here because there's problems. Tell me what the worst problem you see, or if there's no problems.
Thank you. Neil Eicher from the Hospital Association. I agree with Michelle. We took a giant step forward with the healthcare system with the passage of the Affordable Care Act. Problem is, what do we do now? You can see the hospital industry, struggling during these transformative years. And what we need is a glide path, a bridge from the state government, from the federal government to ensure that hospitals, as we're undergoing significant changes in how we deliver care, the quality, the enrollment piece, that we continue to have that support. It's one thing, and it's a great thing that we expanded Medicaid to about 300,000 more uninsured individuals, but it's one thing to give someone a Medicaid card. It's another thing to make sure that they have access to proper
Okay, so
provider.
we're looking at, we're going to allow people to talk about other issues, but what is the singular most serious problem that you face as hospitals with the healthcare system? Because you mentioned Medicaid, Obamacare. Which one is what's the most serious problem you face? Is it money?
It's always money.
Okay. Of the money issue, within the money issue, which is the most serious of the problems?
I think a support for uninsured individuals that, despite Obamacare, you'll still have 550,000 undocumented and people just don't have access to insurance.
Okay. Let's continue to move around the table. So what I'm trying to do is get to the issue as quickly as possible and avoid as much rhetoric as possible.
My name is Ted Kastner. I'm a
And if you get as close to that microphone as possible so everyone can hear you, that's also good.
Thank you. I'm a healthcare provider for persons with developmental disabilities. And from our perspective, the greatest concern right now is the inability of people with disabilities and chronic illness to access appropriate services through the Medicaid program.
Okay, I just want to make sure I'm clear. Access, affordable, did you say affordable services? Appropriate.
Correct.
And can you just give us one example of what you mean by that?
There is a significant shortage of mental health providers in New Jersey.
Did you say mental health providers?
Correct.
Okay.
And people with developmental disabilities who receive that benefit through managed care cannot adequately access that service.
Commissioner?
Thank
And,
you,
and you
Michelle.
can tell us, you know, who you are, a little bit of a background, so we know at least where you're coming from a perspective.
Thank you, Assemblyman. Michelle Kent, currently representing nonprofit senior programs and services throughout the state. I think from our perspective, as you all know, seniors are real high-end users of health care. The lack of coordinated care is probably one of the highest cost drivers and also counterintuitively often results in much lower quality care.
Can you tell us what you mean by coordinated care?
I can, thank you. Often an insurance company or a hospital or many of different entities hire a care manager. That could be a nurse or someone who's able to oversee the care that an individual gets. And if it's coordinated, you know, New Jersey is the highest user of Medicare services. Much of that is because the care is not coordinated, and there are a plethora of tests given, often duplicative tests, and we have a perverse incentive in this country where, unfortunately, physicians, and this is not to knock them in any way at all, get paid every time someone goes, regardless of whether the diagnosis and the treatment is the right one. So a care coordinator oversees the individual's care from start to finish, and with the hope that that will end up in better care.
Thank you. Louise?
Thank you. I'm Louise Lindenmeyer. I'm Director of Government Affairs for Bayada Home Health Care. As a home care provider, and I can speak for other home care providers here in the state of New Jersey, from pediatric services to geriatric services, our biggest issue is with the reimbursement under managed Medicaid. Our reimbursement is close to or below the reimbursement since the year of 2000. This not only impacts our employees, but it impacts the providers, trying to meet the challenges of all the regulatory requirements within the state and the unfunded mandates that we have today and our mandates that will be up for tomorrow. As a result, our workforce...
Well, what we're trying to do is move around the table. You're saying not getting paid enough.
Not getting paid enough.
Okay. Well, you know, if we keep it simple, you know, then we'll get to the solutions. And because what happens is we all get absorbed in our own worlds, but the public generally simply wants to know, so what are we talking about? So nurses and your practitioners, just it's hard to get them to work at that whatever the rate is, correct? But now you got the Chamber of Commerce. You have Matt next to you, right?
Thank
now,
you.
Matt, what is the most serious? What are you here on behalf of the Chamber of Commerce for?
We hear employer affordability. The costs of healthcare keep rising, and it's harder for our member businesses to meet their commitments to their employees.
Okay, so therefore, you're sitting next to somebody who represents nurses who's saying, we're not getting paid enough, and you're concerned about the fact that so much money is going to healthcare that Chamber of Commerce members can't afford to pay for the services, or for, let's say, the premiums. Is that right?
Yes.
So you're looking at costs. That's your focus.
Yes, sir.
Okay. Let's go to some of the doctors and the doctor from the Dental Society.
Mark
Dental
Vitale.
Association. Go ahead. Sorry, doctor.
Mark Vitale. I'm a practicing dentist for 30 years and officer of the New Jersey Dental Association. From our perspective, the biggest concern is the accessibility and affordability secondary to the lack of education and prevention with the disease we treat. We treat the most prevalent chronic disease in the United States, and we treat the most curable and most preventative disease in the United States.
So what's the problem?
The problem is we need help with educating the public. We need help accessing those individuals that do not have access to the education. We need help from the government with regard to that.
Okay. So you want the
also help-
government to get
and
more
help-
involved in education with respect to people and dentistry.
The New Jersey Dental Association would like to partner with the state government and with the insurers in a group effort to educate the individuals with regard to prevention.
Yeah,
and
we probably
more
can do
savings.
that. That's probably the easiest problem to solve. We can probably educate. Angela, you're from Partnership for Drug-Free New Jersey?
Yes. First of all, thank you, Senator. Assemblyman.
Thank you. Senator is just an easier term. As I said, nobody knows what an assemblyman is. I was at a rest stop halfway down the turnpike, and two guys come by my car, and they see my license plate, and it says number 1 assembly. He goes, "Which assembly of God are you with?" So,
Picking
that's-
up on the doctor's
Go ahead.
point, I think prevention in substance abuse is crucial to reversing the alarming trends that we've seen here in the state of New Jersey. There are some legislative bills that are currently pending that would provide some of that assistance.
and how does that affect either the healthcare system or healthcare costs?
Well, I think if we prevent someone from entering into an addiction, then I think we're going to be saving, tens of thousands of dollars on treatment. So I think if we stop the addiction before it begins, I think we can all be in a better
Well, think
place.
about it. We had two solutions right there in the back row: more education with respect to people and their dental care, and if we educate people or keep people off drugs, we'll save money there. Those are, I don't say easy, but at least they're clear. Christine from NJBIA.
I would echo.
And you get it close to that, maybe get that microphone up there so people hear you.
Okay.
Thanks.
How's this, better? There you go. I would echo what Matt said about affordability and value in healthcare. I think employers are very focused on that. And then if I can add a second, I would also say just sort of the complexity of offering coverage in light of the Affordable Care Act.
Okay, so offering insurance coverage is more complex than ever. And that's a result of, we'll call it Obamacare for our
Obamacare,
purposes.
yes.
Okay, we'll come back to that. Desmond, who do you represent?
I'm the legislative chair for the New Jersey Association of Underwriters, and we represent...
Who are they?
We represent insurance brokers, and Christine, you teed that up nicely for me, because the complexity...
And if you can get to that microphone again, so everybody hears you.
Certainly the ACA is a complex law, and the brokers, especially the members of the New Jersey Association of Health Underwriters, are educated, and they work daily with individual consumers and small employers to deal with all of that, all the issues that come up. But to answer the question, your question, Assemblyman, the biggest issue facing healthcare today is the cost of care, which translates into affordability.
Will you represent the brokers, would that be correct?
Correct.
Okay, so you're in between the consumer, so for example, the Chamber of Commerce, and the insurance companies?
Correct.
Okay, so you see both perspectives. You see the concern with the purchaser of the insurance, correct?
Correct.
And those who actually offer the insurance or set the rules, correct?
Yes.
Any specific comments as to how you solve any of those problems? We'll move on, but because you're in the middle, I'd like to hear what you have to say about that.
In terms of affordability?
Yes.
Yeah. Well, employers are trying to offer a myriad of plans, and insurance companies are trying to come up with new plans to, work within the system with providers to, plans.
What does that mean?
Well, for example, this semi-commercial there for Horizon, but they have these patient-centered medical homes, so they're working with the physicians and hospitals, and they've designed a statewide network of certain contracted providers that they've come to a certain financial arrangement
So
with.
that would make insurance more affordable if
Correct.
you stayed within the network.
Correct.
Got it.
Yes.
Judy.
Good afternoon, Judy Schmidt, State Nurses Association. I think the number one problem is consumer access to care. For the nurses, it's allowing our advanced practice nurses to practice to the full extent of their licensure without any encumbrance to that.
Well, let's talk about that. The medical society and you guys sometimes have a conflict, right? If there's a problem with access to care, sometimes the medical society said, we don't want advanced practice nurses to handle that. We want to do that. That's an issue that comes up, correct?
Absolutely.
Right. So we're going to get back to, and Ward Sanders, who's probably, Ward's so smart, I never know what his answers are, so we may need an interpreter. But go ahead. So you've heard some of this.
Yes.
Do you agree with anything that's been said so far?
Well, I largely agree with Neil, Louise, and Matt. And here's the central problem, is that one person's cost...
And if you keep that microphone so we make sure it's really clear in the back.
How's this?
That's really good. I like that. That's good. Okay.
No,
And tell us exactly who you represent in terms that we all understand.
Sure. Ward Sanders with the New Jersey Association of Health Plans. We represent the major health plans and insurers in the state, including 5 that contract with the state to serve the Medicaid population. The central problem, I think, here is that one person's cost is another person's revenue. So I imagine myself metaphorically between Louise and Matt here. Insurance companies sit on the pivot point between those 2 entities. On the one hand, they hear from their purchasing public, individuals, employers, unions, state health benefits program, municipalities, it costs too much. It costs way too much. On the other side, they look to the provider community who says, we don't get paid enough. And that's the central challenge. So to me, the biggest barrier to access is affordability. It was before the Affordable Care Act, and it is after the Affordable Care Act. A lot of it was masked with the subsidies that are involved, but it's not really solving that central problem of affordability. So the challenge is how do we provide care more efficiently and better and in a cost-effective manner so that the Matts of the world can afford it and so that the Louises of the world are comfortable that they can provide the care that provides access to consumers. That's the problem. But one person's cost is another person's revenue.
That's pretty clear. Doctor, we have a neurosurgeon with us. I had the privilege of meeting the doctor recently. So, doctor, you heard from actually the insurance companies. How's that going? And it is a neurosurgeon.
I hope this is close enough. I'm Rajnik Rob. I'm a neurosurgeon. The placard here says I represent the New Jersey Neurosurgical Society. I'm the president. I can tell you the neurosurgeons are doing fine, but I think I'm here to represent the patients. And in a quick answer to your question, I think the number one problem is exploding costs, far and away, and that has consequences in terms of accessibility and access to good quality care here in New Jersey. And you mentioned before that when people come to your office to sort of state their position, they don't seem to understand the opposite side's position on an issue. I'm one of those physicians who do not think that the insurance company is the problem. I certainly don't think lawyers are the problem. I think they all provide very, very useful services in this big, complex healthcare environment. And so I'm in agreement with Ward that exploding costs are the big problem. And everybody else here who's sort of echoed that same sentiment and what it means in terms of accessibility.
Thanks, Doctor. Eric Peterson, Assemblyman, also a member of the Health Committee, joined us. Welcome, Eric.
Thanks.
And can you, since you just got up, or you can answer the question, what do you think the most serious problem facing healthcare industry or healthcare in New Jersey is?
I think cost of health care and being able to provide it in a more cost-efficient manner is probably the most important issue facing health care, and how we're going to deliver it in the future so that's cost-effective, and how we're going to change the way that we're delivering it in a more integrated system, which I see out where I live, a more integrated system in the health care coming across, instead of it being individual doctors, individual programs. It's being integrated through, in Hunterdon County, through the medical center, which has a whole system where you go in and they take you from the very beginning as a primary care all the way through rehab, including a nursing home and a rehabilitative care system. So you have everything from start to finish in that system in an attempt to make it more efficient and to keep the costs down.
Thanks, Assemblyman. Okay, I'm back to Ward Sanders. All right, you now are the dictator of healthcare in the state of New Jersey. What would you do, what would you pass as your first executive order to make sure this system works? And it's, because it sounds to me cost is primary in your mind to make sure you can deliver efficient health care, but do it in a relatively reasonable cost scenario, correct?
Correct.
What would you do? There's no, you own the healthcare system. No more legislature, no more governor, yeah, and no more medical society. You can do whatever you want. What would you do? You're going to take over the entire medical system.
Well, first, I feel drunk with power already. But I would say...
that won't last long out there.
I'm sure. To me, there are things that are enormously challenging and hard to fix in healthcare.
I'll ask you, would you put everybody in network so no one could go out of network?
I mean, this is America. People should be able to be in network or out of network. I would say that there are things where New Jersey is an outlier, and those are the things that we should be able to try to fix. In many states, you don't have the challenge with out-of-network, and we call it the out-of-network problem. It's really
I just made you the dictator.
Right.
You can do whatever you want.
Okay. I would require...
The medical society is waiting for your answer here.
I would require that there be some mechanism to make sure that charges are commensurate with the services provided. And you could do that in a number of ways.
That does not occur in New Jersey?
Absolutely not.
Okay. When and where does that not occur where charges are not consistent with services delivered?
Two key areas, and it's where there's no market forces at play. One is in the emergency room setting. If someone happens to go, and when you're on a stretcher, you don't get to select where you go. The doors fly open, and it turns out it's an out-of-network hospital. New Jersey law says, insurance company, you need to pay to make sure that the person is not balance billed.
So the hospital can charge whatever they want. Let's take, for example, a trauma center comes in and there's traumatic injury. They can pretty much send to your insurance company anything they want, correct?
Correct.
Okay.
And I wish I had more dictatorial powers. But
if it was an in-network hospital, and it was someone in the emergency
they've already
room,
agreed upon the price.
Well, and so give me an idea of the difference what the I'm going to call it out-of-network hospital charge would be for the same service that an in-network hospital would charge. Give me some idea.
It could be a 15-to-1 ratio, I'm guessing. But, I'm looking at, there was a prominent case that was in the press, 3 stitches or 4 stitches, I forget, $14,000.
Okay, and what would that be within a hospital that had a contract with the insurance company?
I've heard that it probably should be more close to 1,000.
Okay. Hospital Association. You want to respond to the insurance industry and say, hey, why should you charge $15,000 for 3 stitches when in-network charges $1,000?
First of all, it's a sticker price. No one pays full charges. Second of all, I believe that patient paid $0 for that stitches bill that was widely publicized. There's a state law from a few years back that says for uninsured individuals making up to 500% of the poverty level.
I'm sorry, I didn't hear what you said.
There's a state law for individuals making up to 500% of the poverty level that we can't charge more than 115% of Medicare. And we did an analysis, about 96 to 97% of hospitals are in network with the major payers, and that looking at our discharge data, that the out-of-network situation occurs in less than 1% of patients who are actually discharged.
Ward Sanders is saying that one of the reasons health costs are out of control is because of hospital charges in certain situations. You disagree with that?
I disagree.
Okay. Isn't it true, though, that the reason you need to charge that is because hospitals are struggling and you take all comers, everyone who shows up? Isn't that why you need that law to stay in effect?
Yes, it's a unique law. New Jersey goes beyond other states in the nation that we have to treat all patients regardless of the ability to pay, regardless of services rendered. When a hospital or doctors across the negotiating table from the insurance industry and they offer reimbursement rates that are below cost, the only recourse hospitals have and doctors is to back away from the
But we're only
table.
talking about the emergency room now. And we're talking about situations where you can charge whatever you want. And what they're saying is that is a real cost driver. But isn't your argument simply that hospitals are going to close if you can't charge a substantial amount of money if you're out of network? Isn't that your argument?
Hospitals will close if they don't have the ability to go out of network, yes.
So what are you going to do with those hospitals that are closing? Everybody wants to go to their hospital.
Well, first of all, the nature of this problem is limited, and Neil is correct. Most hospitals are in network. They work, and there's some great partnerships. There's one of my member plans is partly owned by a hospital. It's not all hospitals. It's the outliers that I'm concerned about, and the outliers, it was a $14,000 charge, and you say maybe the consumer didn't pay, maybe because of Help Me Howard was involved, I don't know, but the insurer paid 12. It's still way too much for the services that are provided. Other hospitals down the road are charging a lot less, are able to negotiate, and are all able to make a profit. So I would argue that for most hospitals, this is not a problem. It's the outliers that we need to contain.
Good point. We're gonna open up this discussion, but what other cost drivers exist in New Jersey other than a hospital that can charge, let's say, above what is fair market value for the services?
But the other out-of-network problem is if you do what you're supposed to, you go to your in-network provider, you go to the in-network hospital, but you're treated by a non-par physician. And in many cases, those non-par physicians charge appropriately.
You call them non-what?
Non-participating provider.
Oh, non-participating.
So you go to the hospital, you go to the network hospital, you think everything's okay, but then there's a pathologist, an anesthesiologist, a radiologist, somebody treats you who's non-par. Again, there's a similar New Jersey law that says you got to ensure you got to protect the patient, pay whatever it takes. For the most part, the appetite of the charging practices from physicians is reasonable, but there's outliers,
Okay,
and
so-
that's what we need to contain.
So you've talked about outliers. Generally, your position is most of the hospitals and most of the doctors who participate, it's reasonable, and you can afford to do that as a provider, and you probably can keep costs relatively low. Anyone want to respond that it's not the outliers, it's something else? So if it's true, the only thing that's driving costs in the state of New Jersey are a few outliers who aren't being either fair or reasonable, we could solve the problem. Is that the only issue that exists? Doctor, you got a neurosurgeon.
What I'd like to know, first of all, what Ward talks about is true. There are some, you could describe them as profiteering practices where patients who simply aren't in a position to make a good, reasonable financial choice find themselves in the hospital and they're faced with charges, or their insurance company is faced with charges that are, well, I'm not going to use the word exorbitant, but are much higher than you might find elsewhere. And certainly those charges might be much higher than, say, what Medicare pays or what insurance companies pay for in-network providers. One question I might have is, in terms of the total cost, the budget for healthcare in New Jersey, how much that's an issue. I suspect it's not that much, especially when it comes to the physician aspect. Payments to physicians occupy, a relatively small fraction of the whole healthcare budget. However, there are many other cost drivers, and this is probably a discussion in and of itself.
But you don't disagree with the insurance industry, Representative Ward Sanders, that one of the most serious cost drivers are these so-called outliers?
Oh, no, actually, I do disagree with that because I don't think it's a big driver of cost in New Jersey. I do think that the practice occurs, but it's the nature of outliers. Statistically, they don't occur that often, and the cumulative cost of those charges is really a drop in the bucket compared to all the other charges. Now, when you talk about healthcare costs and cost drivers, there are many things you could discuss. You could discuss defensive medicine, for instance. Right now, generally, there are estimates of the cost of defensive medicine at somewhere between 10 and 15%. I think it's much higher than that. And in case anybody needs a clarification on what defensive medicine is.
You talking about medical malpractice cases?
Right. Basically, doctors covering themselves or hospitals covering themselves, ordering tests that may not be necessary just in case. For instance, the patient who comes into
Well, before we get too specific in that area, you're saying medical malpractice cases drives up the cost. You agree with that, Ward?
I agree with everything he said.
Okay, so we had a doctor, a neurosurgeon agreeing with the insurance company and so forth. That's good. So, now, well, let me ask either the medical society or anyone else at the table, how much discretion are doctors losing today because of the insurance industry's control as to what they do and what they don't do? Medical society, any comment on that?
Yeah, a very great deal. Remember, the whole construct of the insurance industry is that there are two contracts, right? You have a contract with the consumer who's paying a premium for the service they're providing, and then you have a contract with the physician who is providing that service. We don't think that either end of those contracts is going well today. The physician is under great restraint under when they are contracting. It's you know, you're a behemoth of a company with sometimes a small practice that has one or two physicians, and the provisions of that contract will be, you know, as strict as the insurance company wants them to be, let alone the fact that insurance companies are now narrowing their network so that doctors aren't even allowed to participate. So if you want to talk about outliers and out of network, that's actually being created by the insurance industry now, these narrow networks where docs by definition are out of network. So we think the contracting on the physician side is really difficult, but it's also difficult on the consumer side too. Consumers
Well,
clearly...
I understand, but I'm trying to, are your doctors in the medical society concerned about the control of insurance companies on their decision-making?
Yes.
Okay.
I'm a primary care
Doctor,
provider.
go ahead.
A primary care provider. I can't get patients the medication that I prescribe because it's not in formulary.
It's not, I'm sorry, you're going to have
not
to deal.
in formulary. So for example, I was told that I had to have a patient fail on 5 antidepressants before they would accept the prescription for the specific medication that I recommended for that patient, a medication that the patient was taking when they were assigned to the HMO.
And,
I
the
can't
insurance
get-
companies do that because they're trying to control cost, I suspect. Is that the reason they do it?
I'm not going to judge their decision and the basis for it, but I can tell you that patient was stable on that treatment, and that treatment was specifically denied until the person failed 5 times on alternative treatments which were recommended to replace that.
Okay, so let's open it up now to suggestions. You've got 3 legislators here. What would you do in terms of the law to try to affect change in the healthcare industry? Open that. You can do specific to your area, that's fine. We know now that outliers seem to be a problem. There's a question of, and we've always had the out-of-network, in-network issue. And now I'm asking you, what would you do legislative-wise? Now, the dentists seem to be doing okay.
Oh, that's what I was just going to say.
Why are the dentists working so well with insurance companies generally? I don't know if Jim Schultz would agree with that,
yeah,
but
I wouldn't go that far.
how's that
What I was-
model, why is that model so different than the healthcare model?
Well, this is my own personal opinion based on being in the profession for 30 years and being on staff at a hospital. We live in our own little microcosm because we affect very little of the healthcare dollar. That's number one. So there aren't that many people interested in us, including the insurance carriers, except they do make a decent amount of profit off of the dental plans. And very quickly, the example of their profitability there is 30 years ago, the average insurance plan was a $1,000 maximum benefit that you could receive. Today, it's a $1,000 maximum benefit. Years ago, it was a $50 premium. Today, it's a $500 premium.
Right, but what we're looking for is solutions. Is there anything in the relationship between insurance
Yes.
companies and dentists that we can apply to the broader healthcare arena?
Yes.
Tell us what that is.
A sit-down and a meeting of the minds. If you could formulate some type of group where you mandate individuals from the insurance company, individuals who are healthcare professionals, administrators, sit down and meet and come up with solutions one area at a time. I mean, I have to say
Good.
that...
Is that done? How often does the medical society meet with, or the hospital association meet with the insurance carriers? Yeah.
I would offer this. I've been meeting with folks from Michelle and Neil's office on a regular basis. On a
How's that going? Good?
On a project.
Yeah, it is.
It's going well?
It's going well. And I think the I'm sorry, Doctor, I don't know your name.
Mark is fine.
Mark, it raises a very good point, which is that, you know, this is hard work. You got to roll up your sleeves. There's difficult challenges, but sitting down and talking through some of these things.
Is that a mandated meeting, or
yield
you do
results.
that at your
We're working
discretion?
on a mutual project. It's our discretion, and it's gone quite well. I've worked, and I think.
Who else should be at that meeting other than the hospitals and the medical society? How about the nurses? Should they be there as well?
Well, absolutely. I mean, this is a specific project that we're working on, and it's not quite completed yet. But it's to me, it's shown promise that it does yield results if folks sit down, and it's hard. You got to sit down, and a lot of times it's about money, and you're going to argue about money, but there are things outside of the money that can be fixed. So I think that that's really what's, will make some significant, we can make some significant progress there.
Commissioner?
One of the things that has not been mentioned, I use it as an example of good public policy that also is good for the patient, and that's Medicaid managed long-term services and supports. Without going into all that gobbledygook, where it now means that a Medicaid individual is managed all the way from cradle to grave, managed by an HMO. The good part about that is that now seniors will be, I mean, if I took a poll right now, who would like to go to a nursing home, I doubt
Wait a
that
minute.
a hand would go up.
Did you want to know who was a senior?
No, because I'd have to.
What's a senior? How old? Okay, go ahead, sorry.
In my mind, it keeps going up. Right.
So what are you saying? More management of the patient is better?
Here's the deal. If you don't have to go to a nursing home, I think you're happier. No one wants to go there, it's my point. And this forms a good model. At the same token, if you expand home and community-based care so that seniors can get cared for in their home, forestalling nursing home care or maybe preventing it altogether.
And that's not happening in New Jersey?
It's just starting in New Jersey, and it's
we're
the
good.
kind of example that I think needs to happen, where you're saving money, you're making patients happier, and it's good public policy.
Well, before we open it, because I'd like to have questions from the audience, because that's always helpful. I do have one question, and I'm not sure. I guess it's to the insurance industry. When I get a form from the insurance company, I can't understand it. I don't know why I didn't get the money, but I can't figure it out. Is there a way they can make that a little more simple, like in the big letters? And I don't want to put in legislation because I'm against more regulation. But could they put in big capital letters why I'm getting zero back? I don't really mind getting zero if I know, but there's so much on those forms, I can't imagine anyone understands that.
Well, medical
You know,
billing.
they see, like they say, they check off A, and you have to go to the back and find out why A, and then you have to subdivide that by 2. Go ahead.
Well, I'm not sure I'm going to be able to solve that problem. It is a good issue that literacy around this and the challenges in healthcare forms. I got a bill from a hospital doc the other day. I couldn't make heads or tails of it.
That's scary.
I look at my own EO.
See, it's you guys, man.
It's challenging to read an explanation of benefits. So, we
But why
need to
couldn't they
work
put
as a
the
group.
big problem first and all the other stuff second?
What's that?
No, I'm saying, why can't they put on that form something, you did not meet your deductible, and then they can give me the gobbledygook after that?
An executive summary?
Yes.
Yeah, right.
Okay, so, and if somebody wants to add to this discussion, Michelle, Christine, I'm sorry. Sorry, Michelle's up here, sorry.
I just wanted to just sort of highlight the urgency of trying to address some of these problems, because I think that people have raised a lot of really good points that I agree with. And the challenge here is that no one's wrong and everyone's a little bit right, and how do we figure this out? The need, from the employer community's perspective, the need to get better value, the balance between trying to keep cost under control and getting high quality care. And I think that's sort of what folks at the table have been
And your members are telling you that's a problem? Costs are going up and quality of care, when I say quality of care, just the ability to get care,
I think
co-pays are going up?
Is something that they want value for their money, and they want high quality care. In New Jersey, we pay some of the highest health insurance premiums in the nation, and folks want to have good quality care. But they also would like to be able to continue to afford it, particularly the small employers who really saw big increases in their health care costs last year. Our survey found double-digit cost increases.
Would it make sense for the legislature, and then we'll open it up right after this, would it make sense for the legislature to have some no-frills policies that do not have all the mandates that we've passed, and some of these are great mandates, over the years, so, hey, look, this is simply catastrophic care, it may be a total amount of money available, $5,000. Doctor, you want to answer that? And I see Assemblyman Peterson shaking his head. Is there a problem with that type of policy?
No, in fact, that's a great solution. There was a time.
Assuming it meets federal requirements and Obamacare, which is another issue. I'm
Well,
sorry
we were-
about that.
we
Sorry
were-
about that.
We were talking about cost drivers in healthcare, and I just happened to mention malpractice in defensive medicine, but another one is regulation. And when there was once a time in this country, and I remember this when I was a child, there used to be health insurance plans called major medical, where you could insure yourself against catastrophic loss. Really, you know, the bad accident or a major health issue, but the day-to-day things, the doctor's visits, the drugs, the x-rays, you basically paid out of pocket. And that created a marketplace. That meant that if there are two MRI machines in the same town competing for my business, they're going to compete. One of the ways they'll compete is on price, and they know what the other will be charging, and they'll offer me the best price. And just like in everything else in the free market consumer marketplace, prices tend to go down. It happens with electronics, it happens with cars, except of course when there's a lot of regulation on how cars are built. So yes, that would be an excellent solution, but we'd have to get rid of a lot of the regulations
And that
mandating
and that gets
exactly what
complicated.
has
That gets
to.
complicated with Obamacare and whether or not you're insured or not, et cetera. And then I was going to ask how many people actually at this point in time think that the Obamacare insurance legislation is positive? Raise your hand.
I'm sorry, I didn't get the question.
Are you an overview of Obamacare, good or bad? I'm just going to, yeah, just
just
before you
want to
make,
say-
if you're new, if you're in the middle, don't raise your hand.
What it has done
Yeah.
is increase access. A lot more people are insured than
But I
were
heard from
here
the
before.
hospital association, people come to the hospital, but some of those plans, actually, there's actually no payment to the hospital. But anyway, before we get into this, let's open it up. We got a microphone. We've got some very smart people in the audience. Anybody? President of Medical Society, a plastic surgeon, Dr. Cornell.
Thank you. This isn't on.
How's that microphone?
It's
Is there a
dead.
button on it?
Yeah, oh, okay. One of the issues that was not addressed by the panel, which is a very big cost driver, is hospital readmissions, people with chronic conditions, a major cost. It's a major issue to be addressed, and it's actually far outstrips.
Well, what do you mean?
outliers.
Hospital readmission?
Well, let's say, for example, you have somebody who has congestive heart failure. They're in the hospital, they get treated, they then go home. If they do not take care of themselves and follow instructions and do everything they're supposed to do because they don't understand, or they can't, or they don't have the follow-up, then these people can be admitted within 30 days. We see it for diabetes, we see it for lung disease.
Okay, but I'm lost as to what your point is. I understand they don't take care of themselves, and I understand they're
But
readmitted.
I'm not pushing blame here.
Oh, the hospital. Oh,
In other words, what happens, a major driver is a lot of chronic illnesses that require hospitalization, and people get quite ill from them. And so some of the illnesses are things like congestive heart failure, chronic lung disease, diabetes. They require a lot of care, and it's often challenging for patients and their families to do that. So we're not.
What I'm lost
placing-
about is, you mean if there's no coverage?
No. Let me
Yeah.
further clarify. So you get admitted to the hospital, and the doctors take care of you, the nurses take care of you, the ancillary staff take care of you, and they send you home on a regimen. Somehow, during the next 4 weeks, something doesn't work well, and you end up getting readmitted. So that's a major cost driver in New Jersey as it happens.
How do you want to fix that?
Well, one of the issues is there are a number of plans that have come out to try to make that better. There are models for it out of Boston University, University of Pennsylvania. There's one out in Colorado.
But
that
I'm
actually-
confused. It sounds as if you're saying they're not taking care of themselves when they're home.
Correct. When they get
And is that the problem?
Well, it is, but it involves much more of the system. So you need an entire system to encompass these
Well,
people.
what would you change in the system to make sure they do what they're supposed to do at home?
Well, okay, there are about 4 models out there for home care afterwards, advanced care. Many of them involve advanced practice nurses.
Okay.
They
So
involve
what-
keeping in touch
okay,
with
now I
doctor
got
and
it. So what
medical
you're s-
homes.
You're talking to the microphone? Okay, so what
I
you're
may
saying,
be
you
wrong.
need
That
something
some of the
after they
hospitals-
get home is what you're saying.
But they're also not being, if you have a readmission within 30 days, aren't those hospitals penalized for that?
Oh, yes.
That's
Right,
correct.
that's the
Oh, yes.
point,
Oh,
John.
absolutely.
If you go home and you're post-op and you get readmitted within 30 days, for the same exact thing, the hospitals are penalized for that
So
readmission.
the hospital's penalized, and
that's
it's
what
a
you're
problem for
talking-
the patient as well, because the patient's
absolutely.
now sick.
If you're a patient, you don't want to be going back
Okay,
into the
so,
hospital.
so the question here, we have a nurse
I
on.
think the answer is those models that integrate an infrastructure in the community, care coordination, home care services. We have to look at those top diagnoses, congestive heart failure, the pneumonias, stroke, and build an infrastructure in the community that involves nurses.
Okay, so now at least I understand. What you're saying is, in order to lower costs, if you can have some type of infrastructure, so when the person gets home, they could have a regimen, and it could be supervised, or the nurse involved to make sure it's happening, it could save money. Understand?
Well, and that
And
would
I see
save
even the
absolutely
insurance
save
company
big
saying
dollars
yes
for the
here, so
system.
wait a minute, we got some agreement, this is all right, now. And
Just,
Yeah, most of the time what
Wait a
they,
minute, the dentist wants to know whether,
Oh, no,
is the person
well,
going
this
to the
is-
dentist?
yes, sir.
again, looking at it from a different perspective, not a different perspective, but yeah, somewhat tangential. In dentistry, we have what's called evidence-based dentistry. It was formulated by the American Dental Association a number of years ago. What they did an analysis of all the procedures we do. Now, granted, for us, it's a lot less expensive than it would be for physicians because of the number of procedures. But what they did is they took all the procedures and they looked at success and failure rates of the procedures related to cost. So let me use this as a quick example. You come to me with a toothache, and I say to you, you need a root canal, a post, and a crown, and it's going to cost $3,500. And then I give you the option of an implant that's going to cost $4,000. Well, they've done the studies, and they found that over the long term, over your lifespan, that $4,000 is a lot cheaper than the $3,500. And they've done this with a number of things, where they look at the evidence related to the
$4,000,
success-
we're putting you in a network. No, I'm just kidding.
That is
I
network.
I get what you're saying, but I don't want to get away from this point, because you got an insurance industry shaking their head yes, you got a doctor, most of the panel saying yes. So to avoid readmissions, set up some infrastructure. The nurses like it, the insurance company saying yes, and even Assemblyman Peterson is pretty conservative, he likes it.
That's what I was alluding to earlier when you asked me a question as I sat down, which was that in the Hunter Medical Center has taken this on, where you get paid once for a procedure. Somebody comes in for congestive heart failure. You're only going to get paid from the insurance
Bundled
company
payment.
once for that term. So what they want to do is they want to control the care from beginning to end. So they have created a model where they control the care all the way through the end and then follow up, so that the person doesn't come back in for the same care again within that time period, at least, for the congestive heart failure.
Yeah,
So they've integrated this all the way through. They went out and bought a nursing home. They went out and bought a rehabilitative care. They've done a physical therapy program. They have all that within their system for this very reason, because one of the drivers of cost is person goes home, they get sick again, come back for the same thing, and it becomes repetitive. And when it could be once and done, you get repeats coming back. So this was an idea with the insurance companies to pay one fee one time for that procedure.
And so they're saying, get it right,
Get it right, yeah.
and follow up, make sure people don't come back.
I mean, think of it as a consumer, and this is one of the problems with the cost, is that as consumers of healthcare, if you're insured, you don't really concerned that much about cost, nor do you have any way of comparing cost, right? You go to your doctor, he charges something, you get that bill that you don't understand, and you don't know what they did, and unless you scrutinize it, you just figure, okay, and I see this all the time with clients, they say, okay, they paid it, I don't, it's covered by the insurance.
Who cares?
And
Right.
who cares, and that's it. What this does is it changes that in a sense, and it makes the insurance, the healthcare provider kind of the consumer in a sense, to make sure that they get one time and get the fee.
So the question is, what is the most expensive part of the healthcare system? Is it hospitalizations, by far?
If you look at your premium dollar and where it goes, and the claim portion of that, almost half of it goes to hospitals. So I think that, you see evolving models.
So if you keep people out of the hospital,
And
that would substantially reduce costs in New Jersey. It's not Visits to not visits to primary care doctors, correct?
No, right, most of the money is tied up in the hospital. And,
Is like surgery,
Hunter
trauma?
Medical Center is a good example of an evolving, progressive
I
thinking
get that. I'm
facility.
just trying to understand, because remember, we're novices at this, okay? You know this stuff. I want to understand. So the biggest driver.
I would say the biggest driver, I would say the biggest component of
Component.
cost is.
You're right,
is
bad
the
word,
hospital.
driver. But it's hospitalizations and people being in the hospital.
That's where most of the money is.
That's where the money is.
Yes.
Assemblyman, that's true. Hospitals recognized years ago that you save money in the system and it's better for the patient if you keep the patient out of the nursing home, keep the patient out of the ED and the hospitals. I think it's 5% of the population accounts for 50% of the costs. So you have kind of the penalty that the physician was talking about under Obamacare for readmissions, but you also have incentives that are out there from the federal and state governments where if hospitals can partner with doctors, nursing homes, home care, nurses, get together, and if you provide better quality of care and you save the system money, you can share in a portion of those savings, and it's yielding terrific results. I think we're fourth in the nation now in quality, and it's just getting better.
Thanks.
So I do want to talk about this issue of price and cost and value, particularly in the Medicaid program, because it's come up a lot and people need to know how the $10 billion in the New Jersey Medicaid program are spent. About 20% of that goes to the plans for their overhead and profit. It's about $2 billion. The providers who are paid the other 80% want to know whether we're delivering value, whether we're delivering the quality of care, giving the state the bang for the buck that it deserves. But we don't know because the spend, the $8 billion that New Jersey gives to the 5 Medicaid plans is considered proprietary information. So when I've gone to Medicaid and asked for the data from my own practice to find out whether I deliver value, I've been told that it's proprietary and I can't
That's a
have
question
it.
I've had for years. Why couldn't that be reviewed in camera by judges in the state with a penalty of a criminal sanction by releasing the information? Is there a panel that looks at all of that information in private or in camera? And is that the
It was
possibility?
actually done in the state of Massachusetts.
Just tell everybody who you are.
It was actually done in Massachusetts under civil investigative demand.
Just tell everybody who you are.
I'm Dave Knowlton from the Quality Institute.
And tell us what, it's Quality Institute, just tell us what it is, so.
It's a not-for-profit advocacy group in healthcare quality. Massachusetts did exactly that. They actually issued civil investigative demands from the Attorney General and actually delved into the actual, both sides of the coin, not only what was behind hospital charges, but what was behind health plans, costs, and their report is startling, and would be instructive to see here. I don't know whether it would translate to here. The problem we have, as I've been listening, I apologize, I was a little late. What you have in the healthcare system is market forces without any market rules.
Well, what does that mean? Because, I hear these terms and I don't know what anybody's talking about. Market forces without market rules.
What it
Just give
means
me an
is-
example of that.
You were talking about out-of-network earlier on. So you take a bottle of water, that's a commodity, right? Everybody can buy, you can walk out of any store and buy a bottle of water, unless we happen to be in the middle of a hurricane, in which case that bottle of water becomes a necessity. And if somebody...
Well, as opposed to give me an analogy, why don't you just tell me in healthcare dollars what it means? Because by the time I get through the analogy...
I'm trying to say that we regulate when somebody's at a critical stage and trying to get that bottle of water. It's no longer a necessity. It's no longer a commodity, it's a necessity. When you go into an emergency room or you go into a hospital and you're fearful and you're sick, what you're confronting is not a commodity, it's a necessity. And we don't have any regulation on that on either side. We don't have any regulation where a hospital can charge up and charge up and charge up, and it does bleed through to patients. We don't have any regulation on the plan side on who can be in the network or whether when they have enough doctors in the network they don't want to take anymore. What we need is both parties to come to the table and agree on a reasonable set of market rules that will control these very strong market forces.
Okay, we're going to get to it. Anybody else good? Anybody comment? Yeah, great.
Hi, Doug Johnston with AARP. Many of you know me. I have a question I want to ask Assemblywoman Munoz and Neil and Dave as well.
And you're
It
with
gets to the last
AARP,
question.
just so everybody-
Right. I lobby for AARP. In response to the last question, that's what AARP fought for the CARE Act. It was a pretty minor bill, but important to us bill that addresses the whole readmissions issue. And I think it's a model not only in what it tries to accomplish to address readmissions, but the process. And here's the question. I wanted to ask the three of you to talk about how you gave and worked and on this project of the CARE Act, because it doesn't seem like there's enough compromise going on.
Well, let's just talk about we're talking about the readmission, where there was some discussion of having some home care, trying to make sure that people follow the orders of the hospital. Just tell me, I'm trying to get what your position is there.
I'll let them explain the CARE Act and how it addresses readmissions because Assemblywoman Munoz was sponsored. But my point is compromise. We need compromise to address price transparency, out-of-network issues, nurse scope of practice issues.
What is AARP's concerns about the healthcare system? What's their main issue? What do they consider most problematic, or what's their #1 priority?
I should be up on the panel. No, just kidding.
Hey, come on up,
many
man.
of the same issues. And my message is simply where are we all going to compromise? There was compromise to accomplish the CARE Act. We had legislative leadership and the governor's approval to make it happen. That's kind of my open question, but I wanted to ask your panel to talk about, you all represent interests.
And Nancy, if you
just like
understand the
AARP
question,
does.
go ahead, take it.
I do understand the question.
You do?
Well, I obviously understand the legislation because I was the prime sponsor of the legislation. And I think it really goes back to many of the issues. In my view, one of the more important issues is when the patient gets discharged to home, who is, besides the patient, who's involved in that patient's, overseeing the patient's care so that the patient doesn't get readmitted within that 30 days and that the patient can stay home and it is more affordable. So when I heard from the AARP, and Eric just asked me if I was a member, and I am eligible to be a member, because you only have to be 50. But the thing, I see it as a reasonable way to approach an issue which we're all addressing, which is you get discharged from the hospital, whether you're 16 years old or you're 86 years old, if you have a person who has been appointed to receive the same information as the patient is, they can help facilitate to make sure that you, the patient, follow up on your appointments, that you take care of the same kind of care recommendations that you had when you left that hospital.
Well, the Assembly, Ward Sanders was shaking his head, yes. Okay, so now we have agreement. It seems like there's universal agreement on this, that there needs to be follow-up. So,
well, that's why we
so is
actually
that
passed the bill.
Is that in everyone's policy? No, can everyone get when they leave?
It's actually state law, though. And now it's state law, and what's remarkable to me is it's only it's only New Jersey and Oklahoma.
The president of medical society is great. Ward Sanders said, you said it's great. It's a state law. Then it's not happening?
It just got
signed.
law and is implemented.
And I think what Doug's talking about, the compromise was that there was some discussion about who's going to give out the information. But as Judy would agree, that's what healthcare professionals already do.
So to keep people out of the hospital.
Right. As you get discharged from the hospital, whether it's my 16-year-old daughter who had her ACL repaired or my 87-year-old mother with her pelvic fracture, to designate a person who would be in the medical record as providing the information to both the patient and that healthcare provider.
And
Advanced practice.
the act is actually the patient's family member or a friend. But in the absence of that, that's where nursing comes into play. That's the care coordinator, the navigator, making sure the patient understands. Because a lot of times, this patient is in a stressful environment. They're in the hospital. They had a diagnosis. They don't understand. They leave, and now I don't know what to do.
So
That's where the caregiver comes in.
So we're keeping people out of the hospital because it's expensive. We got that part. And we're getting people educated with respect to drugs and dentistry because we need to keep New Jersey healthier. Is New Jersey healthier now than it was 5 years ago? And what can we do to make New Jersey healthier to keep people out of the hospital? Because it sounds to me you've got to keep people out of the hospital in order that the Chamber of Commerce is happy or NJBI is happier because the premiums are coming down. And we got to also make sure that the doctors have some discretion at the end of the day. Okay.
And I
Wait
like
a
to
minute,
say
just a
something.
minute, before we get
Can
to
I
the
just say
dentist.
something
Yeah.
about the dentistry? You know, my father grew up in Texas and Oklahoma, and fluoride is naturally occurring in the water. And and I'm a huge advocate for putting fluoride in the water because, and I'll tell you why. That oral health is critically important for overall health of the population. And I would probably argue that most people in this auditorium today can afford to get their children fluoride in treatments. And I'm a Republican who lives in the suburbs, but it's the poor kids who live in the cities who miss school because they don't have good dental care. And it's not because they can't afford it. And I would actually argue that one of the things that we can do as a state is mandate that they put fluoride in the water, because that would improve the overall health of the kids in the state of New Jersey. And, you know, I know we have people who argue that it's like causes like all these horrible things, but it's not true. And that would be my advocacy.
And you got to love the dentist because it was their idea. You got to love these guys.
And like I said,
man.
my father
You're gonna
never
have
had a
less
cavity in
cavities,
his whole entire
and
life.
you guys are the prime supporters of this.
And apparently, New Jersey adults
as
have
we
the
are too.
worst,
Okay.
have the most number of dental caries of
So-
any state in the nation. And it's because, but that's a policy issue that we could actually make a difference. And
That's terrific. That's a question.
I mean, do you
Thank
agree?
you.
Isn't it a lot cheaper?
Absolutely.
Okay, the dentist, we agree, you guys agree, you're doing everything right, okay? Now, just this question. Okay, education and getting New Jersey healthier is probably an inexpensive way to reduce costs across the board. And anybody want to come up? Come on, microphone's open, man. It's like the city council meeting in Plainfield, you know? It's not like the legislature where no one can talk except the speaker. I like the speaker, just so you know. So,
I'm Richard Satyawan. I'm a volunteer, so I don't get paid. I'm a volunteer.
What? I missed that.
What's that?
You said you're something not get paid. I missed the word.
I'm a volunteer. So I'm a volunteer. I'm a
volunteer. Got
Medicare
it.
counselor, volunteer.
Yes.
I'm an Obamacare counselor, volunteer, Medicaid counselor. So I see seniors, juniors, everybody on the field. Now, somebody said MLTSS as able to keep people outside the nursing home, keep them in the homebound. That is for long-term care. At the same time, CARE Act is passed on, which is going to be implemented now, that appoints a family member. But however, to keep the acute care people outside the hospital as much as minimum, learn from MLTSS so that, like there is a care coordinator for long-term care, can we not have a care coordinator for acute care? What happens is, even though CARE Act says, I was part of advocacy team on that, even though CARE Act says a family person will be appointed, as somebody said, the family person is totally carried away by all the aftercare. My question is, will the insurance company learn from MLTSS so that the care for acute care doesn't stop when the patient leaves the hospital? There is a care coordinator which follows up. It may not be long term, it will be a short term, which keeps the person outside the hospital. When they go for acute care, they were treated for 3 days, but they are not going to go back 30 days again. And think about it, there is, the field says, if there is a care coordinator for acute care, the family caregiver can call the person, and that can be some solution to keep them away from nursing home, from long-term care, keep them as far as hospital, away from hospital for acute care.
Looks like we're on the same page around here.
I do too. I think that's very well put. Yes, and the insurance industry is part of the solution with MLTSS. They've hired hundreds of care coordinators. Remember, even if one were just being jaded enough to just look at this from the standpoint of cost and not overall health, an insurance company is getting paid a fixed amount per member per month for the life of that person. It behooves them to keep them in lower cost care. So there are built-in, and they have nurse care coordinators who do home visits. And this is just getting started, so I don't want to make it sound like a panacea yet, but I think it's all very well intended to help control costs.
Thank you. Just back to this one question, and we talked about education. What are the chances that we can create a healthier New Jersey? Are we doing that now? And suggestions to make people healthier, do you have to put into effect, before I get to the dentist, because they just know stuff, but anybody have any suggestions? Or how are we doing in that area? Anybody have answers to that? Or you,
Sir, let him go. Yes, sir.
My name is Irv Breckner. I'm with a company called Eat Right, and we specialize
What's the name of the company?
Eat Right.
Eat Right.
We educate, motivate, and empower kids, teens, and families to want to eat healthy, develop a burning desire to do so. Particularly important for you as a new grandfather. We find that when kids understand that chicken nuggets have 38 ingredients and only 19% chicken, and they learn the staggering amount of
Chicken
sugar.
nuggets only have 19% chicken?
Yeah.
I knew we learned something at this seminar. Right there. I'm done with the chicken. 19% is only chicken?
That's it.
What's that white stuff in the middle?
A lot of other stuff. Anyhow.
Oh, it's just white stuff. Okay.
Kids are motivated to change when they learn these things. And it seems to me that we've observed that there's hardly any money going into prevention of obesity. You talked about what can make New Jersey healthier. You mentioned the word prevention and education. Most of the money spent on obesity is treatment, hospitalization, diseases, and since dozens of diseases, medical diseases, and so many behavioral issues like loneliness and bullying and teasing are linked directly to obesity, we need to do a lot more. And how do
Are we making any improvements at all? What are the statistics? Are we doing any better with respect to a healthier New Jersey or less obese?
I think New Jersey has pockets, especially in the inner cities, where obesity is 30 to 50% in kids, and nationally, 80% of all adults are either overweight or obese. So it's a huge problem, and my point is that if we look past our current problems and future generations, many experts predict that kids are going to grow up having shorter lifespans than their parents, due primarily to being obese, which starts at a very young age.
It's a really good point. I mean, how much money does the health insurance industry spend on trying to convince people to be healthy? Do they spend money in that area?
Sure. Whether it's a Medicaid plan or a commercial plan, the models are a little bit differently. But, to the speaker's point, this is an enormous, talk about cost drivers.
Enormous problem.
This is an enormous problem. The reason that we spend so much, one of the reasons we spend so much more than we did 20 years ago, you look at the sixth grader from 20 years ago, what they weighed now, look at a class picture, and look at it now. Wow. There's so many kids now today that are obese. The amount of sugar that these kids, my own kid, I won't even start there, but the sugar is a major problem. Obesity, diabetes setting in at really early ages, enormous cost driver. So it is in the plan's interest, it's in the hospital's, it's in everyone's interest to educate good, healthy food
Is the
choices.
chicken any better at
What's
Burger
really
King?
I'm sorry?
Burger King, same thing, 28%? Is it pretty much the same for a Burger King chicken
Your
thing?
guess is as good as mine.
Okay.
I think the key here is that we, as the health insurance industry, need to get to the parents and the kids to create, and government to create the ability for the entire family to understand what's at risk, what's at stake, and develop programs so that everybody together can prevent obesity, which will in turn lower healthcare costs over the long term when fewer people get diabetes and sleep apnea and fatty liver disease.
Assemblyman?
You raise a good point, and one of the things that we're seeing in education is they're taking away more and more of the kids' recess time and time at lunch when they can go outside and play. And if we're really going to make people healthier, they need to be outside or up and doing something and not sitting around on the computer, not sitting playing video games. And this has become a real problem where I actually have a bill in to mandate that K through 6th grade have 25 minutes of recess every day, because at my kids' school, elementary school, they're taking away their recess. They're shutting down the playground because they consider it a liability. They won't let them do anything. They're basically standing around with their hands in their pockets because of trial lawyers.
It's always the trial lawyers. Or that or George Bush. I don't know which one, either one.
But it's become a real problem because if you think back to when I was a kid, every day after school, we played games at school, football, baseball, kickball, what have you.
But that's the olden days, man. It's a whole different, it's a different world.
Yes, but it's those activities that get people involved in a healthy lifestyle. And you look at my age group for a good part, I see a lot of my friends in their 30s, when they were in their 30s, get into some activity because it wasn't foreign to them. Today, the kids don't do that unless they're in some organized sport. So when they advance into adulthood, if there isn't somebody to organize it and make it happen, are they going to do it? And there's a whole class of kids that don't do it at all. They need to be outside, running around, being like kids.
Mandatory recess, baby. Hey, sounds like a mandate coming from a conservative, but I'll go with it.
I'd like to add one more thing into the children. Where do our children spend most of their time? In schools. Where are our school nurses?
Where are they?
Where are they?
In the nurse's office?
No, they're not. They're being phased out of most school districts so that there is one nurse in a school district. So let's relook at what's happening as far as nursing in the school systems.
I think you're raising some points that lead me to my last point, which is the conflict or the intersection of policy and the way kids and parents think. And that is, when a child is not motivated or doesn't want to eat healthy, they'll go to school and they'll throw away all the vegetables and fruit that they're mandated to give by law. When they are motivated and want to eat healthy, they will take that stuff, they will want to have more activity, they will want to watch less TV. So the most important point I can make is we have to motivate our kids and families to want to eat healthy and exercise. If it doesn't come within then, a lot of policy will be wasted. Thank you.
Appreciate that. Yes, Angela?
I'm not a fan of mandates, but I think that mandating oral health exams in schools would be very beneficial. And I'm not talking about me looking at cavities or periodontal disease. I'm talking about looking at the mouth and doing an evaluation where you can see systemic disease, or at least warn the parents in advance about things that are exacerbating themselves in the person's mouth. And it's something we don't have. The dental associations tried to get it going, but we don't have the funds to do it on our own. We don't have the manpower to do it on our own. We have 8,000 dentists. I'm sure we can dig up quite a few dentists who'd be willing to volunteer and go and check kids' mouths, but having mandated oral
Good
health
idea.
exams would be beneficial.
Doc, you wanted to follow up on something?
I agree with the last speaker totally, but it's more than children. It's also adults, and somehow or other we have to socially educate people for healthier lifestyles, eating, social habits, smoking, excess alcohol. You look at all that, and that's really, it contributes to a lot of medical disease, hypertension, diabetes, heart failure. A lot of them relate to bad social habits.
So if we can move on to another, so what we've learned is that keep people at the hospitals is really expensive. Follow up when they leave the hospital, make sure they get the care. Make sure that kids and adults live a healthier lifestyle, and we will save money in this system. What else? A doctor? Another dentist?
Before I introduce my question, it goes back to what you've been asking before, but as far as keeping children
Identify,
healthy,
tell everybody who you are, doctor.
well,
Oh, you don't want?
let me cover.
Secret?
I'm Frank Krause. I'm a orthodontist from Cranford. Thank you. I'm also chairman of the Medical Advisory Committee at the Westfield YMCA. And if you want to see healthy children, and if you want your children to be healthy, they're indoctrinated in that all the time at the YMCA. They have a national YMCA that has best practices for exercise and for nutrition. And they start off at a young age, and they follow it through for the rest of their lives. But that was not my question was, you asked how can we reduce health care costs and make health care more affordable, put more health care dollars out there. Now, there are three issues that I haven't been discussed, and I would like to introduce them to the board. And some of them are in the Affordable Care Act. One is the medical device tax at 2.3%. Does that discourage innovation and raise the cost of medical equipment? That's number one. Number two, we used to have health care saving acts. The families would be able to set aside $5,000 and use it for health care for the children in the family. And under Obamacare, that's been reduced to $2,500. How much health dollars has that taken out of the family income for paying for health care? And then the third issue is, this relates to the insurance industry. What about tort reform on malpractice? If we can keep the malpractices for certain medical surgery and devices that are done in the hospital systems that are different treatment methods at a reasonable rate, would that lower the physicians and the dentists' malpractice insurance to make it more affordable as well? So I'll leave you with those three and see if we can
Thanks,
get some
Doc.
response.
Appreciate
from
that.
Thank you.
You may anybody else who hasn't spoken? Okay. Go right to Ward and Dot. Corner.
Well, I can address several of the comments just made by the speaker. First, the device tax in Obamacare. We think of these large device manufacturers like DePuy Acromed or Stryker as being extremely rich companies, but they actually, like most businesses, operate on very small margins. And typically those margins, a big margin would be considered something around 5%. So if you add a 2.3% tax on that, it really squelches their ability to innovate. Now, this isn't a big cost driver, but when we get to the topic of the quality of care, there's a reason why most of the medical innovation in the world occurs in this country. And part of that has been because until things like this device tax, the cost of innovating has in general been lower here than in places like England or France. But this is not a big cost driver. As far as his third point about medical malpractice, interestingly enough, that wasn't even mentioned in Obamacare, where one could easily argue that apart from lifestyle choices that people make that lead to their poor health, this is the biggest cost driver. Even though estimates come in at around 10 or 15%, people underestimate to what extent standard of care in this country, what we take for granted in the tests that we order on patients, it's become so entrenched in how people do medicine that they no longer even consider it defensive medicine. For instance, the headache that comes in from the emergency room. And if you address that, and they've addressed it in Texas, and of course there's been a large influx of physicians into Texas, whereas in places like New Jersey, there's been a large migration of physicians out of New Jersey into places like Texas. Yes, that works. But it doesn't work immediately because you can move into a more malpractice-friendly environment such as Texas, but you bring your training with you. And that training has been steeped in defensive medicine. It's going to take a long time to eradicate that.
Ward, you want to comment on any of the speakers?
I agree.
And then we'll move on because we're getting close to the end here. So
I agree with everything the doctor just said. I would note on the taxes, there's a range of taxes. I mean, they had to raise a lot of money for Obamacare, and there's a range of taxes in there. And I do think that some of them, ironically, do impede access. The tax on the device tax is, like anything, any tax, it goes into the cost of the services. The insurance tax alone in New Jersey is estimated to raise $8 billion over a 10-year period. About $500 million annually. It goes up a little bit, but average over $500 million. That's ending up in premium.
well, let me ask this question, then we'll see if anybody else wants to. But somebody brought up the fact that insurance companies, because of proprietary reasons, don't open their books. If we're going to get to the costs and the expenditures of an insurance company, why would insurance companies object if it was done, and they've done this in other type of litigation, in camera, meaning in the judge's chambers, in an expert's room, looking at that, even if we get healthier and we have less hospitalizations and better follow-up, and we put fluoride in the water, and we do oral exams in schools, how do we know exactly where those dollars are going if there's not an impartial arbitrator or someone to look at the insurance company books.
So I
Because
think-
the argument of the doctor is, hey, medical malpractice costs X. That may be true, but once again, no one's really examined those books.
Well, it's a fiction, first of all, that the insurance.
I shouldn't examine, but I understand that when you go for rate increase, et cetera, there's some review. But my understanding, not a complete and 100% review.
I guess we need to talk about what it is that you think you want to take a look at. I mean, the HMO profit margins in New Jersey have averaged around 2%.
No, not
Those
the
are published
profit, not the profit margin, because that's a conclusion. The books themselves, to say, just the way the IRS would come in and look at my books, or the Office of Attorney Ethics can come in and look at all my trust and business accounts. If we're getting down to the solutions, why isn't that part of the solution? And Eric mentioned I was a trial lawyer. I don't have any problem with changing laws, assuming that that is the ultimate reason for costs increasing in the healthcare arena.
Yeah, I'm happy to have a further dialogue on this. I'm not quite sure what precisely it is that folks want to look at. There's an enormous amount of financial information that carriers report to the state that are available to the public through open public record requests.
Just wanted to throw that up as we debate the malpractice issue.
I'll clarify for you. We actually made a public record request of the state of New Jersey for the claims data for the patients that we treat in our practice. We determined that we had reduced emergency room and hospital use by 70%. We wanted to know how much money that saved. The state told us that that information was proprietary and was not subject to the Open Public Record Act request. So we're just trying to demonstrate that we add value to the system and that we can compete with any provider in delivering good quality care, value, meeting the triple aim. But we can't see that data because the state and the insurance companies claim that it's their property. That's Medicaid money, it's public money, just to make that clear.
Any other questions or comments? Because we're going to, and we're going to stay around, come on up, we're going to stay around informal discussions, and we'll have a follow-up probably in 3 to 4 months, and we'll look at some legislation as well, and we'll last speaker.
Thank you very much. My name is Joe Goss. I'm from the New Jersey Society for Respiratory Care. And the one issue that, and I don't mean to go back too far in your discussion, but it goes into taking care of the patients at the home. For years now, and I guess the short to your answer, what's important to us is really just recognition. You know, we're one of those unfortunate ancillary services that's discussed in the hospital.
So tell everybody what you do.
As a respiratory therapist, we take care of individuals right from the delivery room through end-of-life care. Myself, I've worked in the acute care hospitals as well as in the home care environment, so I've kind of seen both sides of that. I've not worked in any rehab facilities because that's one area that respiratory is very limited of where we can actually work. But we take care of those individuals that have the asthma, the COPD, any of the lung diseases, all those that are constantly on the rise right now. COPD was mentioned once, I believe, by yourself, and that's one of those diseases that is up, I believe, about 186% as compared to a lot of the others.
So what is your message to the panel?
Our message to us is really from the point of the respiratory therapist is just recognition when groups get together with physician groups, nurses groups. We are the best at taking care of those lung diseases. And in the home care environment, we've worked hard trying to be there and get some type of reimbursement so we can continue to do what we do at home. And we, as respiratory therapists, are not reimbursed for the work we do, just for the equipment we provide. And that, of course, everyone should know is shrinking day by day.
So you'll provide the equipment, but you don't get paid for your services?
As a respiratory therapist, correct.
And is that something that has changed over time?
Nope. Is not.
You've never been paid
We've
for
never been paid for what we've done. Yeah, we've never been recognized at all as far as one of those providers. But there's a lot of home care companies out there that have worked quite hard, speaking primarily to the home care environment, in that they're trying to work to keep the patients out of the hospital with that 30-day time frame. There's been a few companies that I'm aware of that have gone into the home all at their expense with the follow-up care, with visiting the patients. Respect to all the nurses involved and such like that. But respiratory, this is our job, taking care of the lung disease. Even working with like a physician groups and all that, keeping patients out of the hospital, that they would go in for thousands of dollars worth of tests just to find out that all they need is just a short stay of antibiotics and a visit by a respiratory therapist at home. And those are things that can reduce costs down for not having to go in.
We
into
appreciate your
hospitals.
comments.
So-
We've been here an hour and a half. At least I think the discussion is a good start. I've learned some things, and I'm convinced that we can keep this going, maybe through mandatory meetings. Mandatory meetings, we don't like to mandate much, except recess. Sorry, no, I'm in favor of recess. That's why I'm recessing. That's why we're doing a recess. I think it's a pretty good idea, because that discussion, at least I feel as if I've learned a lot. So I want to thank everybody on the panel. Thank you for coming. We'll stay around and talk generally, and if you have some ideas you'd like to have offline, as we now say, we're happy to listen. But thanks to Kane University and everyone who's attended. Appreciate it.